Hi, my name's Tanya Cook. I am a cancer survivorship nurse based at Gippsland Southern Health Service, and I'm also a McGrath cancer care nurse for breast based at South Gippsland Hospital and a stomal therapist. I have been working as a nurse since 1991 and in community nursing since 2000. Over the years, I have noticed a significant gap in service in the cancer survivorship and supportive care needs for our clients. Our project's goal was to implement a person-centred survivorship program aimed at improving accessibility and enhance health outcomes, treatment experiences, and patient and carer wellbeing, and reduce travel burden for our clients in South Gippsland with cancer. Cancer survivorship needs are increasing as cancer detection and treatment options improve and our population age. In South Gippsland, we have limited access to post-cancer treatment support. We are a rural Victorian shire comprising of small towns. It's over 6,600 square kilometres. In our shire, we have two rural health services at Gippsland Southern Health Service and South Gippsland Hospital. We have multiple aged care facilities and GP clinics. If patients need to travel for tertiary services, they are often more than 100 kilometres away in Greater Gippsland, the Peninsula or metropolitan Melbourne. We have limited public transport in our shire, and some towns have no public transport at all. We also have limited taxis, and phone service and internet can be patchy in some areas. The need to travel long distances for supportive cancer care increases financial and physical burden on our patients and carers. Over the years, I have noted that people are more willing to travel for their active treatment, but are less likely to travel for their supportive care. In our project, we needed to understand the tumour streams and demographics in our shire. We also spoke to and surveyed a number of local cancer patients, carers and key stakeholders to develop an understanding of the existing support services and their perceived gaps in care. One of the take-home messages from the patients was the lack of specialist cancer support nurses. In our shire, there is myself as a McGrath cancer care nurse breast based at South Gippsland Hospital, and at Gippsland Southern Health Service there are palliative care nurse care coordinators Monday to Friday and day oncology nurses on Thursdays. We networked and looked at benchmarking and analysis of existing survivorship models of care and realised that we were unique, and we sought governance and approval to develop a tailored model of care with supporting documentations, forms and KPIs. And we needed to establish referral pathways both locally, Greater Gippsland, metropolitan and in the community. Our patients also requested the option of face-to-face appointments closer to home. So we developed a nurse-led survivorship model of care based on flexible service delivery options. We can see clients in 4 different clinic locations across the shire. We can also do home visits, telehealth or phone consults. For those clients that have telehealth appointments with specialists that don't have the necessary technology or know-how, the survivorship nurse can visit them in clinic or at home using their laptop and mobile phone to help link them in with these services. The eligibility for the service is that the patient needed to have treatable but curable cancer. They needed to be living or staying in the South Gippsland local government area, and they needed to have finished or nearing completion of their active treatment. We decided to accept clinician referral or self-referral, given that our referrals would be coming from multiple health services. and some clients may not be referred in and would be able to have the ability to self-refer. We sought approval and implementation of a Tier 2 NWOW-funded outpatient clinic. We did lots of communication and marketing between all of the health services within our shire, the tertiary centres and metropolitan Melbourne and the community. The survivorship program pilot commenced mid-February to December 2024 and is now ongoing. All patients had their distress thermometer, problem list and patient-reported outcome measures on admission with the cancer survivorship nurse. Dependent on the patient's cancer stream and their unmet needs, other assessment tools were used. All clients were also offered post-PROMs. The patients were very appreciative of the holistic patient-centred care that included education and support, care coordination, cancer-specific end-of-treatment care plans, and referrals as required. Some examples of the referrals sent out are listed below. We received 31 referrals during the project. One patient declined but did accept phone support. We had patients between the ages of 50 and 90 of various tumour streams. We did have a lull in May and June as some of our clients were grey nomading and postponed admission. Our patient satisfaction surveys were all very positive. All clients reported improvement in their PROMs from pre-entry into the service to after their initial needs and supportive care, and no one recommended any changes to the program. Of note, all clients surveyed reported supportive care closer to home and reduction in travel burden as being very important. All 30 patients admitted to the project were offered at least one face-to-face visit with a cancer survivorship nurse. These could be in clinic at 4 locations across the Shire or home visits as required. Follow-up appointments were based on the individual assessment of the client and their unmet needs and personal preference. Follow-up appointments could be in clinic, home visits, phone consult, telehealth or email. Patients were appreciative of the holistic assessment, education and support closer to home that reduced travel burden and costs. They reported significant improvement in their cancer care coordination and communication between the patients and the carers and the local and tertiary health services, GPs, specialists, and this program. 4 of the clients developed cancer recurrence or metastatic disease and reported increased unmet needs in information, symptom management, care coordination, transport, and carer support. Technically, these clients were discharged from the project, but the survivorship nurse was able to provide assessment, support, education and referrals and care coordination whilst they were waiting for the multiple tests, GP appointments and specialist appointments to decide whether they were eligible for active metastatic or palliative treatment. In conclusion, offering local clinic or in-home appointments improved access to survivorship care. Linking clients with local quality supportive care reduced travel to Melbourne or tertiary health services. Clients reported improvements in support, care coordination, well-being and quality of life. Expanding the survivorship program eligibility after the completion of the project to include all cancers that are treatable but not curable unless registered with palliative care helped address gaps in local cancer survivorship and supportive care in a rural setting. Thank you.